How's it going, everybody? And in this video, I'm going to be talking about the OMM practicals that you would take in a DO program as a first-year medical student. And so I'm currently wrapping up my first assessment week in my first year of med school, and we just had our OMM practical exam. And so the main focus of this exam was to demonstrate your ability to effectively complete a structural exam of a patient. And so I know probably a lot of new terminology here, so I'll try to explain all this stuff and then talk a bit about like what the actual test was like. So OMM stands for Osteopathic Manipulative Medicine, and it's a key part of what makes DO, the osteopathic physician, different from allopathic physicians, is that in addition to everything else of the curriculum, DOs are taking OMM because that's a central part of the tradition. And so OMM is used for the diagnosis and treatment of somatic dysfunctions, and that's still a pretty broad definition. So what are somatic dysfunctions? So these are things that have conditions where you see changes in the TART. So temperature, asymmetry, range of motion, tenderness, temperature are all examples of things that make up what could be a somatic dysfunction. And to give an example of a somatic dysfunction one could get is something like someone who tweaks their back. And what an osteopathic physician would diagnose for during a structural exam is that they would palpate your lumbar spine, for instance, and they would feel the transverse processes on your vertebral segments, and they would be checking to see whether or not there's any asymmetry in it, because what can happen sometimes is that the muscles get a bit contorted and the vertebra as a whole has these two things sticking out transversely. That's why they call them transverse processes. And so, you know, if it should be in this plane, it actually gets rotated a bit like that or like that. And so DOs are trained to be able to palpate, which is a fancy word for touch, but basically you palpate through a lot of the paraspinal muscles and you can feel the bony structures, those transverse processes of that spinal segment. And it could be multiple spinal segments affected. And so basically, you know, it's not just, oh, let's diagnose someone and tell them like you've got a somatic dysfunction in L2, it's rotated right. Our goal is to also treat these patients and to, you know, work them through articulatory techniques as well as soft tissue techniques to help alleviate their somatic dysfunctions. And so I know, and I will say, you are encouraged to be skeptical. If you think, because I will say, I think there's stigmas associated with DOs, if I'm going to be honest, and I know that MDs can thumb their nose at it a lot and just say like, you know, it's a bunch of hokey pokey stuff. And, you know, at the end of the day, I think the real validation doesn't come down from whether or not, you know, oh, this was a somatic dysfunction, it wasn't a somatic dysfunction. It comes down from whether or not the patient will tell you like, yes or no, I feel better now. So, you know, for a lot of patients, especially patients whose healthcare plans don't necessarily include all the expensive imaging like Xrays or MRIs. I know Xrays are cheap, but still not every insurance policy is going to cover it. DOs can do quite a lot and they can really help out people. And so, you know, in addition to ordering X-rays and MRIs, which a DO can do, DOs have this additional capability of performing OMM to help treat a patient in that exam room right then and there, and it only takes a couple minutes. And so it's a pretty powerful technique that you know, you really just have to use it and apply it. And you know, it's used to treat headaches, and I personally have had it done to me where one of the physicians, the osteopathic physicians, was basically, you know, helping kind of just relieve some of the tension in my head. And, you know, there's a bunch of techniques on how to do this and a lot of research goes into it. And I will say I felt a little bit better afterwards. So, you know, I encourage everyone out there to just try it, you know, have an open mind, see if it helps. If it does, that's great. And, you know, especially if you plan on doing something like primary care, having another tool in your toolbox to help a patient is definitely something that's worthwhile, in my opinion. But that's a little bit of a detour. So now getting back to what a structural exam would look like and what type of thing you're going to get tested on as a first year DO student in med school is the following. So basically, structural exams, it's very rushed, I will say. I didn't completely finish. I got most of it done, but there was stuff that I still didn't fully do, like assessing passive range of motion of the patient, where I'm actively moving the patient to feel whether or not I'm feeling any stiction. It's a term my dad would use. But any stiction between like the vertebral segments as you're flexing, extending, side bending, or rotating their back. And so that is something that you got to get really fast at it, and obviously I'm still pretty inexperienced with it, so learning how to do these tests quick and be efficient and smooth, it's all just something that comes from like muscle memory and a lot of practice. But I think the key thing that they want to take away from first year medical students isn't even necessarily like your technique's perfect, like obviously it won't be. They just want to know that what you're doing. You're verbalizing what you're doing and why. And so, if we talk about assessing a patient from the anterior view, which is, that, you're looking face on at that person, are you able to successfully assess like their gait, their stride length, their cadence, their knees in relation to each other? Are they bow-legged, which would be called genu varis, or are they kind of like looking like their knees are pointing in towards each other, which would be called genu valgum? Are you able to assess their rib contours? Are you able to assess their shoulder levels if one shoulder is like much higher than the other? Earlobe levels, and is their head side bent or rotated when they're in a neutral position? Are there any skin defects or deformities? So like that's one example of part of the structural exam, is just looking at the patient, asking them to walk forward and back for you, noting anything you see. Antalgic is like a key word you'll hear sometimes. So someone might be limping on their right leg, you would say they'd have an antalgic gait. They might be a positive on the Trendelenburg test, which means that they don't have strong hip abductors, so that glute medius, glute maximus muscles. And so like, I think it's a really important thing to note here, is that we have so much technology these days with MRIs and CT scans and Xrays and all these different technologies that are out there. It's great, but it discounts, I think, a lot of what you can do with your own two eyes and your hands. And so I think OMM is definitely something that is often overlooked, but is very valuable, and it's a very useful tool in the toolbox. And I know I'm repeating myself, but the whole point of the structural exam is to just show people, your professors and the TAs, that like why you're doing what you're doing. Like when you're going to do a soft tissue prone pressure technique, why are you stabilizing the ASIS, and why are you applying that anterolateral force, and what does it mean to break up your cross links and to increase the gags in the muscle fibers in an area of hypertonicity? So there's just a lot of kind of technical jargon, I know, but at the end of the day, the DO profession has lived on since A.T. Still, back when he started in the Civil War, and I think that really speaks to the merit and the benefit of this practice. And so it's something that I'm glad I'm getting at least an exposure to. I can't say for sure whether or not I'll actually use it in practice if I do end up practicing, but it just think of it as another tool in your toolbox. Like, you take anatomy because you got to learn all these muscles, nerves, veins, ligaments, arteries, tendons, forwards and backwards. Very similar thing about OMM is like it really kind of gives you an appreciation for what you can feel as you palpate through the skin and into the fascia and into the muscles and through to the bones. You can really feel a lot about what's going on, if it's cold, if it's dry, if it's moist, if it's a lot hotter, if it's more hypertonic. your fingers are very, very sensitive things that I think people think, it's just too basic, it's too simple, like we need to have an MRI. And a lot of times, speed is critical in some of these situations. And if a physician's able to diagnose something with their hands right then and there, you can make actions on that. And so it's a pretty powerful tool. But yeah, so in terms of the exam, you've got the anterior view, you've got the posterior lateral view, which is just the fancy way of saying the side view from the patient's side. So like you're assessing their spinal curvature, you're assessing stuff like, are they able to successfully perform a squat test, which confirms if they've got good lower extremity range of motion actively. You're checking for stuff like their gravitational line to make sure that their lateral malleolus, their greater trochanter, their acromion process, and their external auditory meatus all line up with each other. And then you check from the posterior view of the patient. You can assess for scoliosis to see how their ribs kind of rise and fall as the patient is leaning forward and coming back up. You can assess for issues with their SI joint, their sacroiliac joint, by palpating on the patient's pelvis and feeling for the PSIS segments, and then asking the patients to flex forward and extend back up, and note if you feel any asymmetries there. So like there's just a lot of stuff you can tell about the body from being in the right place and having the patient go through a certain motion. And so it's a very, very powerful technique. There's basically a checklist of things that you need to look for. And so if you forget stuff, obviously you're going to get marked off. So a lot of it felt like you're learning a script for a movie kind of. And, if you forgot some lines, then you're going to lose some points. And if you didn't know why you're doing a certain thing, you're going to lose some points, because you've only got 20 minutes to really go through the whole thing, and to also, you got to talk fast while you're doing stuff to explain, why are you assessing for pes cavus or pes plantar. There's a lot of just technical words you got to learn. So in that sense, it's kind of like acting, and you're kind of learning how to act like a osteopathic physician before you become one and before you actually start practicing clinically. So definitely a big learning curve to a lot of this stuff, but I don't think, in relation to a lot of the other practicals that I've had this week, like anatomy and the standardized patient encounter and the didactic, like the OMM practical is pretty just straightforward, honest, and not something to stress too much about. Like it's really just showing that you understand the core concepts, and that if you were asked to do a structural exam, you could do it and you would do it well. Or you would at least know why you're doing a particular part of the structural exam. So yeah, that is some very hopefully interesting stuff and insightful stuff if you guys are interested in what is it like to be a DO and to go through a DO program, as well as see what a OMM practical is like. And my dad was an MD, and he kind of looked down on DOs, and I think a lot of this ego and prestige stuff just comes down to people not really understanding the profession that well, or the practice, and not keeping an open mind when they should. And it has very real repercussions. And a part of history that they taught us, and this is the last thing I'll say, but during World War II, the MD lobby, so a bunch of MDs have a lobbying organization in Washington, D.C., and they actually lobbied Congress to not allow DOs to serve their country as doctors during World War II, because they thought that only MDs would be qualified to act as physicians in that capacity. And for me, that's something that's a very dark mark in history. And I will say that there's been other times in history where MDs have, it's a very complex relationship. There's a lot of history to it. There's some drama. At one point in time, if you had a DO, you could pay money to this MD organization, and they would issue you an MD license. And so the notion that, and I've spoken about this too, but it's just like the notion that, oh, MD is better than DO. But if you look at history, like there's been times where you could have just swapped your DO for an MD if you paid some money, like a $50 processing fee. Makes it all seem like it's really just the same thing, and even the MDs know that. And if anything, and it just kind of the conversation has negative connotations to it, and like what I'm trying to also get to here is that these are both very unique, important, and relevant professions, and they take slightly different paths, but you end up doing the same work. Like a DO can specialize in anything that an MD can specialize in. It might be a little bit harder because MDs have more prestige, and so there's going to be stigmas associated with an MD applying to some kind of particular residency program perhaps, but that aside, there's nothing legally keeping a DO from doing something that an MD does. And so yeah, it's definitely stuff that I think is good to know. And as I've said previously, also, like, our goal at the end of the day is to serve our patients and to improve health outcomes and to develop effective treatment plans that are making sure that they are in the patient's best interest and that the patients are part of the conversation. And so that's the key thing to take home here, is that we're all on the same team. And I hope this stuff is helpful, and thank you all for watching. Let me know if you have any questions, and I'll talk to you guys next time.